So thank you very much for the opportunity to speak today. So I'll be speaking about assessment of surgical leadership, which is an often overlooked but very important area of competence. So the objectives today will be talking about what is surgical leadership. We have to assess something, we need to know what it actually means. What programs do we use to develop leadership skills, and actually what programs do we lack? What tools exist to assess leadership both in training and in practice? And then where do we go from here? How do we actually improve our ability to take care of leadership? I have no disclosures, and I suppose I have to leave the 7 seconds, as you mentioned, but we're going to skip that. So what is leadership? And if you look to the dictionary, it's actually not a very helpful definition. So it's the office or position of a leader, the capacity to lead, or an instance of leading. And frankly, this is how I feel about that. It's a very circular logic. So how do we actually apply this to figure out what surgical leadership is so we can actually assess it properly? Well, a few years ago during the presidential address for American Surgical, Dr. Ledgerwood talked about what happened to surgical leadership, and how she defined it was in 4 different ways. That a surgeon is responsible for guaranteeing and improving quality, for excellent patient care. You're responsible for development of yourself and your development of others. That's a part of leadership. And then one of my favorite parts is actually sharing the joy and the privilege of our profession as part of leadership as well. So if you apply this to our day-to-day life, there are many facets of our job that actually involve leadership. There's clinical leadership, which is your conduct in the operating room with your team, all of your interactions with your trainees, your colleagues, your staff, and patients. You can be a clinical leader by advancing different methodologies in the operating room. You can be an educational leader through your instruction of colleagues, trainees, and the public. Part of leadership is educating yourself and committing to self-improvement. There's administrative leadership in terms of quality improvement, your roles on committees or divisions and departments, and in societies, both locally, nationally, internationally. There are surgeons out there who are chief medical officers, who are CEOs, who are deans of medical schools. So leadership in surgery now encompasses all of these different roles. So how do we prepare ourselves for these kinds of leadership positions, and how do we assess our ability to attain them? So many societies have leadership development programs. In trauma, which is what I do, the Eastern Association for the Surgery of Trauma has a leadership development workshop every year. The ACS and other surgical societies sponsor people and promote a program at Brandeis that's for health policy and management leadership. The ACS Department of Education does multiple programs that are given every year. There's the Residents as Teachers and Leaders course that allows a weekend for residents to go and learn how to do this. There's also the ACS Surgeons as Leaders course for operating room to boardroom. And just this past weekend was the Leadership and Advocacy Summit from the ACS. But these are short interventions. Is this actually enough to develop leadership? There's more literature coming out about how do we develop leadership during residency. So a couple of years ago, somebody published about rebranding the lab years as professional development years. And what they said is that we have to develop a skill set that applies surgical expertise beyond the confines of the operating room. And in a reply, a few surgeons from Stanford talked about how they've developed their program during these professional development years to grow leadership capabilities that enhance success as future leaders in the field. So this is just part of what we do. However, there's no durable or long-term leadership programs in many residency programs across the country. So what are some of the challenges for the assessment of leadership? Well, first of all, how do we assess leadership when it has so many different definitions? Assessment of leadership for someone who wants to be a clinical educator may be very different than somebody who wants to be a CMO or a CEO. What tools do we actually have to assess people with leadership? And then I would challenge you all, how many times do we assess leadership in our trainees or in our colleagues by just using a gut feeling or by a nebulous application about how we feel leadership is supposed to be done, as opposed to using objective qualifying parts to leadership? So looking at leadership in residency in particular, we talk a lot about the core competencies, and these are essential parts of how we assess residents over the course of their development. And I'm not going to list them there, but you know the 6 core competencies. Well, look at this one. So interpersonal and communication skills. On the left is the current competencies. On the right are the ones that are coming out to start in 2020. So here they talk about the resident assuming overall leadership of a healthcare team. Well, if you look at the new competencies that are coming out in 2020, that word disappears. Leadership is no longer there. They talk about aspects of leadership, so coaching, facilitating a team, communicating, but that actual word of leadership, that discrete term, goes away. And this isn't the only competency where that disappears. So currently, we talk about the resident being capable of leadership when unexpected events occur. In the new competency, they've actually reworked what this competency is about. And again, that word leadership is gone. So how do we expect our trainees to get better at leadership or understand what their own leadership potential is if we've gotten rid of that term? It's not as though leadership isn't in the competencies, it is. You can see that here, there are many different competencies that talk about mentoring, advocating, participating in projects to improve quality, coaching, all of those things. But the actual specific term of leadership has disappeared. So the core competencies are essential to resident development and achievement, but leadership is nested in these competencies and isn't actually clearly defined. So I would say that we're not providing enough discrete feedback on leadership ability to our trainees for them to then move forward towards these leadership positions. So maybe we need to take some of what we're doing and change some of these bullet points to figure out where we should go next. There are tools out there to assess surgical leadership, but I would say that currently they are underutilized. This is a tool that I've used both clinically, but also in research practice, the non-technical skills for surgeons. And this is something that talks about 4 different types of non-technical skills. So situation awareness, decision-making, communication and teamwork, and then leadership. And these are rated on a scale of 1 to 4. And this is specifically made for the operating room. If you look at leadership in particular, they talk about leadership as leading the team in providing direction, demonstrating high standards of clinical practice, and being considerate about the needs of individual team members. They then split that into 3 elements: setting and maintaining standards, supporting others, and coping with pressure. The great thing about this system is that it splits it into evidence of good behaviors and poor behaviors. So you can use this not only as an assessment tool, but as an instructional tool as well, to teach people about what leadership should actually look like. And while this is made for the operating room, it's something that can then be tailored to simulation scenarios, real-world scenarios. You can actually use these elements to try to actually assess people. This doesn't just have to be for trainees. This is for practicing surgeons as well. You can do surgical assessment of leadership on teams, not just individuals as well. So this is the non-technical skills scale, or NOTEX. One of those elements is leadership and management. And again, it looks at leadership, at maintenance of standards, planning and preparation, and workload management as aspects of leadership. Again, it's on a 1 to 4 scale, and this is used to assess teams in the operating room, from surgery to anesthesia to other aspects of the team members. So this is a way, again, that discreetly can assess leadership in real time and can be used. So what does this actually tell us? Surgical leadership is evolving. It encompasses a diverse set of roles, including clinical roles, educational, administrative positions. Structured leadership programs do exist. However, many of them are short-term. They're not the longitudinal ones that we need in order to improve leadership as people go along in training and in practice. An assessment of leadership is limited and often very nebulous. We don't specifically name it. And discrete tools do exist, but we're not utilizing them properly. And I would submit to you that we can and must improve. So how do we do that? Well, first of all, we have to acknowledge and encourage different types of leadership. You have to find out, is your trainee or your colleague, are they aiming to be a CEO? Are they aiming to be a dean of a medical school? Or are they aiming to be an excellent clinical surgeon? That will change how you want to develop their leadership potential and how you're going to assess it. We need to integrate specific leadership instruction throughout the years of residency. It can't be limited to a weekend course. Those are fabulous. They're incredibly helpful, but they're going to get lost if you don't repeat them or reinforce them throughout training and throughout your practice. And then you absolutely have to routinely assess leadership, but in a more discreet fashion. People need to know that you're providing them feedback about their leadership ability, as opposed to just indirectly talking about it. And this is the way that we're going to be able to move forward and actually develop the leaders that are going to be able to move forward tomorrow. Thank you.